Good afternoon, everyone that stayed for the night session of the autoinflammatory disease. Thank you for that. And this talk is about a challenging case that I had with an autoinflammatory disease, and it's more clinical. I showed the evidence for treatment in the previous talk. So it was a patient with a fever, arthralgia, and rash. And she was a 54-year-old female who was born in Ukraine and immigrated to Israel with no chronic disease until then. At the age of 12, she had rheumatic fever, and in 2008, she had bilateral panuveitis. She was also a chronic smoker, and she came to our clinic because of 20 years of ongoing attacks. The attacks were arthralgia of the feet, of the ankles and knees, and these were accompanied by a rise in her fever to 39 degrees and severe weakness. And she also described a burning rash over the arms, her torso, hips. And usually the attacks started in the afternoon and in the evening and lasted for a short period of time of 3 to 5 hours. So during the attacks, she showed us her very thick medical record. She had acute phase reactants who were extremely elevated and marked leukocytosis. And the frequency of the attacks ranged from a few times a year to daily attacks, depends sometimes even on the weather. She denied night sweats or weight loss, and her physical examination was normal. She didn't have lymphadenopathy. There was some mild, very faint rash on her arms when she was in the clinic, and also she had a heart murmur of mitral stenosis. So later on the day, in the evening, she sent us the pictures that she took of her rash, because what we saw was only a faint rash, and this is the rash that she had. In this picture, maybe you can see it better. It resembles, you can say that, describe it as an urticarial rash. So she had a past evaluation for approximately 20 years of evaluating, a very thorough medical evaluation, including chest X-ray and ACE levels, complement levels, which were normal. Her rheumatoid factor was persistently elevated, but her protein electrophoresis and cryoglobulins were normal, and her immunoglobulins levels were normal. Also, her ANA and hepatitis status was negative. The urinalysis was normal, and she also did a total body CT as part of her evaluation, which was also normal. And on echocardiography, she had moderate mitral stenosis, probably due to her rheumatic fever in childhood. So I will go over the medical evaluation that she got through 10 or more years. And I'm sorry, the pictures are in Hebrew, but trust me, the translation is accurate. In 1998, she had a skin biopsy which showed urticarial vasculitis. This was one of her first encounters in Israel with physicians, the dermatologist. And then on 2001, like 3 years later, her symptoms preserved the whole time. So they admitted her to the dermatology department, and they put her in isolation, an isolated room from the environment, to check what is the allergen that gives her this urticarial rash. And they gave her elementary diet so they can know which food causes the allergy. And they also gave her antihistamines during the hospitalization, but there was no improvement in her rash, and they didn't find any specific cause. So they discharged her with antihistamines. In 2003 and 2006, she saw several times a rheumatologist, and he describes here that there are musculoskeletal diffuse chest pain at the same time when there is a rash in her skin, and everything disappears after a few hours. And he says that she was already diagnosed with urticarial vasculitis, and he can't find any rheumatologic problem. So he finished with that, his evaluation. So in 2009, she was again in the dermatology clinic, still suffering from these attacks of rash and fever. And this time they did another allergic test, like patch tests, and she was found positive for some substances like nickel, another something very long substance that is written here down. And they recommended to avoid jewelries and to avoid belts with metal, and to see what happens. And they recommended another skin biopsy. So of course another anti-allergic drug, and of course nothing helped. And she did another skin biopsy, but this time it was not urticarial vasculitis, but just no specific findings in this biopsy. And then in 2011, it's already 13 years since she had her first skin biopsy. She went to an allergologist who is also an immunologist because the symptoms continued, and he describes here her symptoms. And his recommendation is to go to a dermatologist or rheumatologist to see what is the problem. So she went through many years of evaluation without a diagnosis. And this is her rheumatoid factor levels through the years from 1997 to 2011. We can see that it is persistently elevated, and also her ESR is persistently elevated through many years, and her CRP, the same, always elevated. Whenever you check her CRP, it is elevated. So she also have chronic inflammation. So to summarize the clinical picture, she has recurrent short episodes of urticaria-like rash, accompanied by fever, arthralgia, and general weakness. She had a thorough investigation without a diagnosis. And when she came to our clinic, it was in 2012, the frequency of attacks increased to daily attacks. It was actually during the winter, and she still suffered very much from her disease and still was seeking evaluation. So what is the diagnosis, differential diagnosis of a patient with periodic fever and urticarial rash? So of course, urticarial vasculitis is a possible diagnosis. Rheumatologic disorders like lupus, Still's disease, and some kind of vasculitis. Hematologic disorders like Schnitzler syndrome or lymphoma, etc. Cold-induced urticaria, which is a physical urticaria which is caused by cold, but it is usually local and not systemic, without systemic inflammation. Cyclic neutropenia can cause recurrent attacks of fever and sometimes a rash. And of course, autoinflammatory diseases, and the most common and the main autoinflammatory diseases that were discussed today, FMF, TRAPS, CAPS, and hyper-IgD syndrome. PFAPA is not so fitting here. And I like this picture from 2008. It's very old, but it's still good. And here they look at different characteristics of autoinflammatory disease, and they have these arrows to point to which disease you should suspect. So they look at the therapeutic response to colchicine or to prednisone. They look at the length of the attack, the trigger of the attack, the inheritance, if you know it, what kind of skin rash the patient has. Is it erysipelas-like in FMF? Is it migrating erythema or urticaria? And other clinical features like serositis, meningitis, hearing loss, lymphadenopathy, many symptoms or manifestations of autoinflammatory diseases. So we went to that picture actually and put the manifestations of our patient here. So the length of attack is very short. It's a few hours every day in the afternoon, less than 1 day. She did have uveitis in 2008. Her rash is urticaria-like, and also, as I mentioned, she didn't say that, but her symptoms were worse during the winter. So maybe there is something with cold exposure as a trigger. And if we look at all these manifestations, it points to the disease CAPS, mainly to CAPS. So we sent her for genetic diagnosis for CAPS to mutations in NLRP3 gene, and we did find a mutation, the A469V mutation in her gene, which confirms the diagnosis of CAPS. So just a little elaboration about CAPS. It is cryopyrin-associated periodic syndrome. It is composed of three main subgroups of disease, from mild disease to more severe disease. The milder is familial cold autoinflammatory syndrome. Muckle-Wells is more severe, and NOMID, as you have already heard, is the most severe phenotype. It is caused by the mutation in the NLRP gene. It's a gain-of-function mutation. The gene is located on chromosome number 1 and encodes for the protein cryopyrin, and inheritance is autosomal dominant. This is a cartoon of the cryopyrin. As you can see, it activates caspase 1, which in turn activates pro-IL-1 beta to activate IL-1 beta. And IL-1 beta is released from the inflammatory cell and causes the bouts of inflammation. So if there is a genetic defect in this cryopyrin protein, then there is spontaneous activation of inflammation and release of IL-1 beta. This is the NLRP gene mutation. So many mutations were found, as can be seen here in this gene, and as can be seen by the colors, depending on the specific mutation is the phenotype of the patient. So if it is a mutation which is here in red, then the patient will have NOMID or SINCA, the most severe phenotype. If the mutation is blue, the patient will have the Muckle-Wells phenotype, and if the mutation is purple, the patient will have FCAS, which is the mildest form of CAPS. So this is the mutation that our patient had, the A439V, which is mild, and points out that she has FCAS. So what is FCAS? It's the mildest form of CAPS. Usually exposure to cold results in a systemic inflammatory response with fever, urticarial rash, conjunctivital injection, uveitis sometimes, and arthralgias or arthritis. The symptoms can occur daily, particularly towards the afternoon or the evening, and the attacks can appear even in the absence of cold exposure. In the laboratory, there is leukocytosis, sometimes very high counts, like 30,000 and more, and the attacks usually resolve within 24 hours. They are short, and if you take a skin biopsy, you will see a marked infiltration of neutrophils, and this is as opposed to the regular allergic urticaria where you will see eosinophils. And the treatment, after we know the mechanism was found out about the cryopyrin and the IL-1 beta, is IL-1 blockers like anakinra, rilonacept, or canakinumab. So if we go back to our patient, after we did the diagnosis, we took her history again, and she said that apparently she had uveitis starting at the age of 2, and her symptoms started very early. We recommended canakinumab, which is reimbursed in Israel for CAPS, and her symptoms ceased immediately. And until this day, she takes canakinumab. It's been 11 years that she's on canakinumab, and she's doing very well. She doesn't have any attack. Her CRP levels are normal, and it's a very satisfying case. So thank you very much.